That's a great question, because how they might affect it is that we've got to do what we're currently doing even better with the new drugs. You think new drugs might make it easier, but it actually makes it more cumbersome, because you've got to place those drugs in the right position. So what we've got to do, since we have some new drugs for multi-drug resistant organisms, we've got to make good decisions up front about our empiric drug choices. And those empiric drug choices will be very dependent on an individual institution's susceptibility patterns. Each institution will have to make good decisions with their pharmacists, microbiologists, infectious disease physicians, and others about what drugs will be used in their empiric choices. If they're having a big resistance problem, one of these new agents might take the place of something else. If you're not having a resistance problem, that drug will be moved further down the line for when you do see a resistant organism, not initially. So that's how it affects stewardship, in that where you place those drugs need to be the appropriate place, so that we don't overuse those, because regardless of how good they look right now, eventually bacteria are smarter than us and they'll become resistant to those bacteria. So placing those, I think, is how the new drugs will change it the most. And then, of course, if those are part of our empiric choices, once we get culture and sensitivities back, that de-escalation to more specific therapy, that's a key, huge part of stewardship that has to be done. And so that will even be even more important.